Happy New Year and welcome to 2008 and yet another in an endless series of Persiflager's infectious disease podcasts, a review of the infectious disease literature with snarky commentary. This one is going to cover the last 2 weeks of December of 2007. If you like this podcast, of course, please log on to iTunes and let the world know. Brought to you by Pusware LLC, the publisher of the Persiflager's annotated compendium of infectious disease facts, dogma, and opinion. Your Uber hyperlinked guide to infectious diseases. All the opinions are those of Mark Crislip, MD, and Puswell, LLC. I need to say that because this is CME accredited. Listen, take the online quiz, and get a half an hour of free CME. Thank you, Legacy Health System. Also, to mention any potential conflicts of interests, I have none. There. Are you happy? The references to this podcast are online, now hyperlinked to PubMed, so you can go right to the source if you don't want to believe what I'm telling you. And finally, don't forget my Quackcast, a review of supplements, complementary, and alternative medicine, i.e. scams, also available on iTunes, and leave behind more to the world than just your irritable and surly offspring. Participate in the ID Wiki. Help increase the world's knowledge at idwikibook.org. Now, on to the literature. As HIV enters into another decade, it's nice to know that patients with this disease are becoming more and more normal as they age rather than dying of HIV-related infections. This study was published in the journal Neurology and looked at cognitive function in AIDS patients over a 5-year period and found the patients who were on highly active antiretroviral therapy and kept their viral load suppressed declined just like I've been doing over the last 50 years, age-related changes in cognitive performance. But it would appear that brain functioning is preserved when HIV is well controlled. How much HIV-related dementia is reversible, I do not know. This might make for a good advertising campaign for our patients, as early intervention and treatment of HIV disease will prevent them from turning from a Democrat into a Republican. If you prefer, you could say prevent them from becoming a Republican from a Democrat. There. For those of you who are the thin-skinned Republicans that occasionally listen to this, I've tried to make you happy. So what do you do with blips? Not blimps, blips. You're taking care of an HIV patient, and all of a sudden you get some very slightly detectable viral load that then disappears. Is this important or not? This study was published in the Clinics of Infectious Diseases and looked at a population who was on lopinavir/ritonavir as part of a safety and efficacy study in combination with a variety of reverse transcriptase inhibitors. And every once in a while, patients would blip up with a viral load of about 82 and it would fall. Was this significant? The answer was yes and no. It was significant in that the blips were usually associated with decreased adherence to medications in the week prior to measurement of the viral load. So there will be a little breakthrough, and it may be a hint in your patient that they're not taking their medicines like they say they are. Not that your patients would ever tell you something that wasn't completely the truth. The other thing, however, which was more important, is that these little blips were associated with neither virologic failure nor resistance to lopinavir/ritonavir. So it would appear that these little blips are, in this population at least, probably insignificant, but it may be a hint that your patient needs to take their meds a little better. This next one just reeks of something that will show up on the boards. Now, I don't write the boards, and I have no ins into the boards, but this was in the annals, and the people that write the annals write the boards. And this is concerning a multicentric Castleman disease, which is a lymphoproliferative disorder that is occurring in increased frequency in patients with HIV. It also is associated with human herpes 8, also the cause of Kaposi's sarcoma. So there's at least 2 board questions right there. This small series of patients were treated with rituximab, which is a monoclonal antibody against T cells. Specifically the CD20 cell. That sounds like a third potential board question. And this small series of uncontrolled HIV patients with Castleman's who got rituximab did very well. So this is a potential treatment of this disease in HIV patients, and you probably now have at least 3 board questions answered if you can remember this. Renal failure and AIDS is a bad combination, and this was brought home in an article in Clinical Infectious Diseases that looked at the use of antiretroviral therapy in HIV-infected patients with chronic kidney disease. They found it was not uncommon for patients with chronic kidney disease and HIV not to be on appropriate medication, and when they were underdosed. As a result, they estimated about a 25% increase in excess mortality in this VA population. I keep trying to do my Tazon Day imitation and turn away from the mic when I inhale, but be that as it may, having chronic kidney disease is not a contraindication to being on highly active antiretroviral therapy, unless, of course, you're a veteran. Getting old is not optimal, but it beats the alternative. But if you get influenza, you're much more likely to die if you're old. Now, this study looked at the effects of oseltamivir on patients in Canada who were sick enough to be hospitalized for influenza and found a decrease in the 15-day mortality in patients who received oseltamivir for their influenza pneumonia. Now, the interesting thing about this study is that they found survival benefit in patients who received their antivirals greater than 48 hours after onset of symptoms. Usually the rule of thumb is that if you've had influenza for greater than 48 hours, that the drug will not be effective. However, in an older and immunocompetent population, viral replication exceeds the usual 48 hours and may account for the success they saw with later use of oseltamivir. The depressing thing, however, in this study is the number of patients who were vaccinated. About 70% of patients were vaccinated and still had severe pneumonia. This is the ongoing problem that those who most need a vaccine, like influenza, may be the group who's least likely to achieve benefit from the vaccine. Although not statistically significant, those who were vaccinated were more likely to survive than those who did not. I don't think this is an argument, of course, against vaccination, but more the importance that everybody is vaccinated, then the chance of giving it to an older person decreases. But the take-home message, if you're in influenza season and someone's admitted even after a vaccine with a viral pneumonia that looks like influenza, start their oseltamivir sooner rather than later, as you will get survival benefit in that group. See, stuff just keeps on a-coming. And if you remember last week, we talked about how telbivudine is better than adafovir for patients who have hepatitis B. In this study, which was published in the New England Journal of Medicine, they compared telbivudine to lamivudine and found that telbivudine was better. It had better suppression of hepatitis B DNA with less development of resistance. So it's looking, when compared head-to-head, that the treatment of choice for hepatitis B is going to be telbivudine rather than adafovir or lamivudine. Now, what about the manifestations of what we like to call Ted Nugent's disease, or cat scratch fever? Da-da-da. Boy, I'll never make it as a singer. This study was published in Clinical Infectious Diseases and looked at the musculoskeletal manifestations of cat scratch disease, and it turned out to be surprisingly common. They looked at 96 patients who had cat scratch disease, and 55% had myalgias, sometimes severe. 41% had severe arthralgias. 13% actually had arthritis, and a smattering of patients presented with tendonitis, back pain, neuralgia, and to clarify the breakdown, they had 900 patients with cat scratch disease. 10% had musculoskeletal complaints. And what I just said was the breakdown of the musculoskeletal complaints in patients with cat scratch disease. When I think of fever and severe myalgias, I tend to think of influenza, group A strep bacteremia, and not uncommonly Staph aureus bacteremia. Now you should probably add Ted Nugent's disease to the list. Dun, 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 dun. Which podcast but the Persiflagers podcast gives you classic rock? I know I have to keep my listeners happy, and there is a big group of people who do nothing but worry about babesia in my listening audience. There was an interesting article in Clinics of Infectious Diseases that had an AIDS patient with refractory babesia. They gave the standard therapies and it did not work, and they finally eradicated the babesia, by giving him a combination of red cell exchange as well as atovaquone proguanil. So there's another potential therapy for babesiosis. What to do about community-acquired MRSA probably defines the concept of problematic. A brief report in Infection Control and Hospital Yes, I speak in tongues. The name of the journal in question is Infection Control and Hospital Epidemiology, and they did a retrospective analysis as to whether or not mupirocin treatment was beneficial in preventing recurrence of MRSA, and the answer was no. The nasal colonization did not affect recurrence, and that nasal mupirocin did not decrease recurrence. This is probably because community-acquired MRSA is like the pigpen model. You remember Pigpen from Charlie Brown? He was covered in a haze of dirt. People who are MRSA positive, the community-acquired MRSA, tend to be in a haze of this organism, and sticking a little salve up their nose is like urinating on a forest fire. Being old and jaded, I'm not often surprised by articles published in the medical literature, but this one did surprise me, and it looked at gram-negative endocarditis in patients. This was non-HASIC endocarditis, and they managed to scrounge up a total of 49 cases of endocarditis in 61 hospitals in 28 countries. So it's not that common. The majority had prosthetic valve endocarditis, which did not surprise me. But here's what did surprise me. E. coli, not Pseudomonas, was number one as a cause of gram-negative endocarditis. This accounted for almost 30% of patients with endocarditis. The other thing that surprised me is that the majority of patients had implanted intravascular devices such as pacemakers and defibrillators. Now, the usual take-home message is that it's very unusual for gram-negative rods to seed prosthetic material such as pacers and defibrillators. Again, it is very unusual, but it does happen according to this article. The other unsurprising thing is that these gram-negative endocarditises were usually nosocomial, big surprise there, and they had a 25% mortality rate despite high rates for surgery. No big surprise there. Having a gram-negative rod on your heart valve is a bad thing. But it does happen occasionally in the hospital that some poor sap will get the E. coli from the urinary tract, seeding their pacer or their valves and develop endocarditis. Okay, I know these were not like huge surprises like winning the lottery or something, but, you learn something new every day. At least I try to, and that's why I read the literature. This next study looked at risk factors for developing Clostridium difficile disease, and it had the usual suspects that one would expect for being a risk for developing C. diff. Use of quinolone antibiotics, use of third-generation cephalosporins, but there were some others that were probably a little more surprising. If you'd been in the ICU for a prolonged period of time requiring mechanical ventilation, if you'd received anti-motility drugs, if you'd received H2 blocking agents or proton pump inhibitors. But here's the key one, which you probably would not think about. The use of intravenous vancomycin was found to be an independent risk factor for the development of C. difficile, probably because the amount of vancomycin you get in the stool is not enough to treat Clostridium, but is enough to wipe out all the other more susceptible bacterial flora, putting you at risk for developing C. diff. So that selective pressure of intravenous vancomycin, which we're using by the buckets load, thanks to all the MRSA out there. But remember that use of vancomycin parenterally is a risk factor for C. diff. But curiously, metronidazole is protective, which would be counterintuitive to a lot of people who think incorrectly that metronidazole is less efficacious than vancomycin in the treatment of C. difficile. An ounce of prevention is still better than a pound of cure, or an ounce of perversion is better than a pound of pure. And it's better to prevent C. diff than to have your patients get it, or other antibiotic-associated diarrheas. I think the evidence is becoming pretty clear that the use of bacteria-containing yogurts is a good thing in patients who are receiving antibiotics. And in the Canadian Journal of Gastroenterology, they did a blind placebo-controlled trial where they compared fermented milk that contained lactobacillus placebo, and those who were on the lactobacillus-containing milk had a marked decrease in the amount of antibiotic-associated diarrhea. They had 89 patients, and twice as many patients got diarrhea who were on the placebo than who were on the fermented milk. This has been confirmed now in multiple studies, so I think it's now a reasonable thing to do in the right subset of patients. You can find more details on this whole issue on my Quackcast. We all know people with particularly tight anal sphincters, the amazing ability to turn charcoal into diamonds. However, it can be a problem in some people that can be treated with the injection of botulinum toxin into the muscle. I mention this because there was a case of a diabetic patient who had an injection of botulinum toxin into his rectal area for a tight anal sphincter, and he developed necrotizing fasciitis. There are a whole bunch of case reports of patients getting botulinum toxin in places other than the face, and as a consequence getting a bad infection. So while the use of botulinum toxin might be a potential cure for the typical cardiologist, don't forget that all good deeds go unpunished, and that every time you stick a needle in someone, you get a chance to get them infected. I consider this to be job security. Trying to diagnose Aspergillus pneumonia in the immunocompetent patient, much less the immunoincompetent patient, is always difficult. This study looked at using BAL for galactomannan and found it not to be an unreasonable test. They had 110 patients who had, in the end, 26 proven cases of invasive aspergillus. They found the sensitivity of the test to be about 42%, which is not too bad in this particular disease, so that if you have a patient who's very ill with progressive pneumonia negative cultures, and they often end up getting bronchs with BALs, sending it for a galactomannan assay may be a reasonable thing to do. The downside is that, at least in my institutions, the labs always get wiggins when you send down a body fluid for which there's no standards, and the current CLIA regulations have taken all the fun out of ordering weird labs on patients. But since the diagnosis in some of these patients was only made on BAL and not on blood galactomannan, it is a worthwhile test to do in some patients. There has been some data to suggest that hospital-acquired urinary tract infections increase mortality rates. This study was done out of France and looked at 3,000 patients who had catheters, of whom 10% developed a urinary tract infection associated with their Foley. While the overall crude mortality was increased in patients with a urinary tract infection compared to those who did not develop it, when they did the usual matching and adjustments, they actually found the catheter-associated urinary tract infections did not increase ICU mortality. Now, the interesting thing and the important thing to remember in this study is not so much the mortality rates, but the fact that 1 in 10 developed a UTI. And starting next year, American hospitals are not going to be reimbursed for hospital-acquired urinary tract infections. 1 out of 10 is pretty good in an ICU setting, so I'm sure your institution is no better, and you're no longer going to get paid for it. Now, the average hospital-acquired urinary tract infection only costs about $1,000, but how about line-related infections, which are also not going to be covered soon? So what are the risks for line infections? Well, the University of Chicago Hospital managed to find 142 nosocomial line-related infections, none of whom will be reimbursed in the future. And they found in this study, which looked at who got gram-negative infections, that there were 3 things that were really associated with developing a line-related bloodstream infection due to gram-negative bacteria. One is having surgery in the month prior to your bacteremia. The other is diabetes and hypotension at the time of the blood culture. So diabetics who have surgeries are at higher risk for developing central line infections due to gram-negative rods. And when they get it and get sick and end up in the ICU, your institution will not be reimbursed for it. Remember, however, that a significant percentage of line infections can be decreased by simply using full barrier techniques for putting in a line and, get this, washing your hands appropriately. What a concept. Hand hygiene. We've only known about it for 160 years, so I'm not surprised that it hasn't taken hold yet in this country. As long as we're on the topic of saving money because of urinary tract infections and the like, it turns out that often catheters are placed for the wrong reasons. In this study that looked at the use of catheters in a hospitalized patient, they found that a whopping 28% of patients had a urinary catheter placed for no damn good reason whatsoever. 26% had their catheter placed for inappropriate urine output monitoring, and 18% due to urinary incontinence. So a large percentage of patients had catheters put in when they didn't need one. And in this institution, 14% of their catheters resulted in urinary tract infections, none of which you're going to get paid for. And speaking of inappropriateness, a curious article in Israel looked at the appropriateness of antibiotics on weekends versus weekdays. They looked at discharge from an emergency room and had a pair of infectious disease doctors figure out whether or not the antibiotic was appropriate. It turned out that if you hit the ER on a weekend, you had a much higher chance, odds ratio of 0.35, of having inappropriate antibiotics given at the time you were discharged from the ED. So it's of interest to note that another thing that leads to, perhaps at least in Israel, to inappropriate antibiotic usage is being seen by a doctor on the weekend. Of course, healthcare in the United States is second to none, mostly because we are a dismal 15th at best. This is shown in an article published online that looked at the incidence of things like parasites in American citizens. It turns out that a quarter of inner-city blacks have roundworms, that about 14% in the South have Toxocara, the dog tapeworm, and that neurocysticercosis now accounts for about 10% of seizures in Los Angeles, so that the burden of parasitic diseases approaches that of Africa in some parts of the United States. This article also points out that we've spent millions and millions on bioterrorism, such as anthrax or smallpox, while we continue to let the poorest and most deprived of our society suffer from diseases that are preventable and should only be seen in unindustrialized third world countries. Sigh. But at least when we get hit by bioterrorism, we will be prepared. Not. That's it this week. Only 22 and a half minutes of my random babbling. There are 2 nice reviews in clinical infectious diseases, one on posaconazole. The other, if you are interested, is on stenotrophomonas. But otherwise, I have nothing else to talk about this month. So this is the end of the Persiflager's podcast, a review of the infectious disease literature with snarky commentary. References, as always, are available online and now linked to PubMed. Now get your CME. Take the online quiz, get a half an hour of free CME thanks to Legacy Health Systems. Also, if you're a medical student wondering what to do with your life, Legacy Health Systems offers an excellent training program in internal medicine, www.lhs.org. Brought to you by Pusware, LLC, the publisher of the Persiflager's Annotated Compendium of Infectious Disease Facts, Dogma, and Opinion, your uber-hyperlinked guide to electronic diseases at pusware.com. If you like this, go online and write a glowing review on iTunes. Don't forget the Quackcast, and don't forget the Infectious Disease Wiki, what will hopefully one day be the ultimate online ID reference, www.idwikibook.org. Finally, this is copyright by the Creative Commons 2008. And as always, thank you for this most interesting consultation, allowing me to participate in the care of this most difficult and challenging case. I will continue to follow along with you. Thank you, and dictation. Goodbye.